Welcome to the Ricky Matthews Show from the Citizens Bank Studio. I hope you're having a great day as we continue to celebrate so many amazing people, really across the state of Mississippi, who are working so hard in the trenches to make this such a great place to live, work, and play. Hey, listen, our first guest today had a technical issue, and hopefully we can get her back on. But instead of having Singing River Health Talk in the second half of the show, we're going to have it in the first part of the show. But before we go there, I just want to mention something that is something that I want to send a thank you. Actually, I had the opportunity. I got a call from Greg Payne. His wife Penny and him wanted me to be a speaker at the Harrison County Republican Women's Federation or organization monthly meeting. Not exactly sure how they talk about themselves, but I decided to do it because I have a long association with Greg. And, it's interesting, throughout my entire time as a publisher of the Sun Herald, I never got involved in anything political. And even to this day, I don't contribute to political campaigns. Even on this show, I try to stay out of the pure political discussions. But I decided to go because, again, I wanted to, as a favor to Greg, but plus I just wanted to get out. It was a small group and a chance to interact. And I really enjoyed the interaction. And in fact, it kind of inspired me. I probably ought to get out more. Other than do this show, I don't get out too often. But I really want to thank Penny and Greg. I think she has done a terrific job. In fact, she's the president of the Mississippi Federation for Republican Women, and she serves on a few roles for the National Federation of Republican Women. But I really enjoyed spending time. I didn't actually give a speech. We just talked, and they had lots of questions about some Katrina learnings and what's happening with media today and newspapers and all that. That was the kind of conversation it was, but it was really terrific, and I really enjoyed it. So I want to thank them for inviting me and to let them know I sincerely enjoyed the time we spent together. Okay, so let's turn the page now. I have been thrilled to be part of this new segment on the Ricky Matthews Show we call Singing River Health Talk. Singing River is just a terrific leader in the community, not just on the medical side, but just in the community in general. And I think this is the fourth installment about that. And we have really, really enjoyed doing them and having the conversations with professionals who are engaged in the trenches for Singing River Health System. And today we're actually going to talk about pain management. And I had the opportunity to spend a little bit of time before the show started with Dr. Joshua Dibble, and he and I, had a chance to kind of see where each other comes from, and he's very passionate about what he does. And you will appreciate when you get to know him here shortly that this ribbon cutting that's coming up, the celebration that's coming up at Singing River Interventional Pain Management Clinic in Gulfport on April the 16th is a really important moment for Singing River Health System. And I'm looking forward to having Dr. Dibble on to talk more about it. So without any further ado, let me welcome him to the Ricky Matthews Show. How are you doing, my friend?
I'm doing well. Thank you for having me on today, Ricky. I really appreciate this opportunity. Thank you.
It's good. It's good to see you. Hey, so just let's frame what's happening. What we're going to do, we'll talk about the significance of this opening of the Singing River Intervention Pain Management Clinic, and then we're going to take a step back a bit and talk about your Gulfport boy, Southern Miss, went on to Denver, and then ultimately to the University of Mississippi. We'll talk about all those things, but before we do that, talk about what you're involved in now.
Well, where do I start? No, interventional pain management is on the cusp of a major transformation. Pain management 25 or 30 years ago didn't have a whole lot of tools at our disposal. It was largely medication and simple injections like epidurals that many people maybe heard about. Well, currently we still do those things, but we have so much more. We have tons of new technology, new procedures, new interventions that we can do to address pain in a variety of different ways. And that's really where my focus is. There's a big problem with chronic opioid use in this country, and we don't need to have a long discussion about that. But I will tell you that the current trend in pain management is away from long-term opioid use, and it's more towards what we call multimodal analgesia combined with interventional therapies. So, that's really what I'm passionate about. That's what I'm doing. And that's actually what I've been doing all morning long. I've been doing procedures all morning, and I'm just grateful to take a little bit of time to chat with you.
Well, I think it's terrific, and we'll get into some of the details of that here in just a second. But you think about Singing River opening the Interventional Pain Management Clinic in Gulfport. In a way, you've really come home in a way, haven't you?
Oh, absolutely. And this is something that I've been thinking about for a long time. So, becoming a physician is a long training process. And as you kind of mentioned earlier, I did medical school out in Denver, Colorado, but I always had in the back of my head I was going to come back here. So I ultimately came back here and did my initial anesthesia residency at the University of Mississippi in Jackson, and then I went on to do my interventional pain management fellowship there as well. And so very happy to be back here in my home state. Got a lot of family here, and Gulfport's my hometown, so I'm super thrilled to be here practicing.
Listen, I'll tell you a quick story. I have what is called a hypersensitivity to narcotics, and I had to go through. I had a surgery many years ago. It was for a hernia, and I had a severe reaction to the narcotics. I mean, honestly, it caused seizures in a big way. And they said, "Oh well, you must have some kind of hidden epilepsy." So they started me on Dilantin, and the long story short, I was doing some training for the Sun Herald at the time, and went up to South Carolina to work at the newspapers up there. And while I was there, I went to the neurology clinic at the University of South Carolina, and I'll never forget his name. Dr. Julian Adams is who I spent some time with. And he diagnosed that, no, Ricky, you don't have diabetes. Not diabetes. You don't have epilepsy. You have a hypersensitivity. It's very rare. But it is something you have to, you need to wear a medic alert. You don't need to be on Dilantin for the rest of your life. Get off of that. You're not going to have a seizure, and just be very careful next time. So I've had another surgery since then, and made pain management really tricky, as you can imagine. But how often have you dealt with someone like me that has to have surgery and can't really take the traditional pain medications and post surgery?
Well, hypersensitivity to your degree to opioids is not common, but it is not uncommon to have people that, for various different reasons, either can't take opioids or opioids just for whatever reason are not the best choice for them. So believe it or not, that's more common than you might think. Again, not your specific condition, but it's very common for people who can't take opioids but are going to have a procedure. So how do you deal with that postoperative pain? And the short answer is you deal with it a lot of different ways, and we can kind of get into that a little bit more. But it's a multimodal approach. There is no one replace the opioids. You kind of have to do multiple different things.
So let's retrace a couple of things real quick. You mentioned medical school in Denver. I think it's important for people to realize that you had to become an anesthesiologist before you went into this specialty. So why don't you give people a sense of that background?
Yeah. So originally, obviously trained in anesthesiology, where the way I look at that role is you're the person as the anesthesiologist who gets a patient through surgery or any procedure safely. And that involves keeping them asleep, keeping them comfortable, and then also making sure they're comfortable when they wake up. And so there's a big aspect of pain control that's involved with anesthesiology, although that's not the only thing that you do, but that's a part of it. And so I practiced anesthesiology actually with Singing River down here on the coast for about 4 years, but I always had interventional pain management in the back of my head. And I finally just kind of, just took the plunge, so to speak, and went back to training. And now I'm doing what I really, really love and enjoy.
You know what's interesting to me? I just calling from my own experience. My mother, who passed away a couple of years ago, she had some pretty serious back issues. It took her a while, and this is many years ago, but it took her a while to find a doctor that could intervene in her case that wasn't about just giving her drugs. So pain management meant getting lots of drugs. And as as caregivers and people who were really wanting her to enjoy her life, having her mental faculties about her, we really worked hard to make sure it was being managed properly, But there were some pain management doctors that kind of gave you guys a bad name because it was all about pouring on the medication. I bet you have heard about that and talked about it, this sort of new age a pain management physician is a whole different class of physician, isn't it?
Yes, I would absolutely agree with you on that. And, not to disparage any colleagues, like I kind of referenced earlier in the talk, you know, doctors are kind of limited by the tools they have available to them. And, 25, 30 years ago, there weren't nearly as many tools as there are today. And so those tools 25, 30 years ago were, medications that were largely opioids, and then maybe a few simple injections or procedures, but they didn't have nearly the gamut of tools that we have today. So,
let's do this, Dr. Dibble. We're at the end of this segment. He can't actually see us, so I had to use the stock with words. When we come back on the other side, let's pick it up right there and explore that part of what you do. So we'll continue with Singing River Health Talk right after this break.
All right.
Welcome back to the Ricky Matthews Show for today's, this week's version of Singing River Health Talk. We're talking about pain management with Dr. Joshua Dibble. And we had to cut him off. He on his view of what we're looking at, he can't actually see us. So usually we have a counter clock that's counting down, and we put a finger up and we do these kinds of things. But he's been a real good sport for us as we work through getting the show done today. But you can see him and hear him, and he's very articulate. Obviously, you can tell from the way he is passionate about what he's doing. When we went to break, though, you just mentioned the opioids, and why don't you pick it up from there?
Yeah. So the way I kind of view the whole situation with the opioids and how some people practice pain management is, doctors are a little bit limited by what tools they have available. And, 30 years ago, it was largely opioids and a few injections like epidurals. There were a few others, but that was kind of all the options you had. And so that's what doctors did. Well, now things have evolved, and we definitely have a lot more options. And we know a lot about opioids now. And again, we don't have to have a long discussion about that, but we know that there are some definite downsides of opioids and some problems there. And so the focus on, the new focus on interventional pain management is away from opioids. It's on other medications in a multimodal approach, and it's on interventions. And so that's where my practice is.
And what you probably find, doctor, is that when you're dealing with patients, they are a lot more aware of opioids today. And, it's not, whereas before, just give me what I need to take care of my pain. It's not that simple anymore, is it?
No, it's not. And, I'm kind of benefiting from many patients who have been on opioids for a long period of time, and I have a frank discussion with them. And there's two real things with opioids that you can't get around, and it's tolerance and dependence. And very briefly, tolerance is kind of what the laymen think of as addiction, meaning, whatever dose you're taking today is not going to give you the effects that you need. Maybe 6 months down the road, you're going to need more of that drug. So that's tolerance. And then dependence is kind of what layman people think of as like addiction. Okay. So if you stop taking this medication, you have withdrawal symptoms. So those are two big problems with opioids, and there's almost no way to get around them. So that makes it very challenging to give opioids on a long-term basis, although it used to be done. But we know so much about that now, and it's just, in my opinion, it's not the best option for long-term pain control. Doesn't mean people don't have pain, that lasts longer than 2 or 3 months. It just means that maybe opioids aren't the best choice for those patients.
Yeah, I see that clearly. I was looking at the list of services and procedures. You have a lot of tools at your disposal, don't you?
Oh, absolutely. Absolutely. I mean, I've been mentioning epidurals, and people have heard about that. That's where we put medicine in the epidural space. It's the same space, by the way, that when women have a baby and they get an epidural to help with the labor pains, that's the same spot that we put medicine in. And that can often help with pain that travels down the legs, what we call radicular pain. Now, that's been around for a very long time. It's a very safe procedure, and it works for a lot of people. But like I keep referencing, that's kind of where treatments largely ended 30 years ago. Now that's kind of where treatments start. We start there, and we have so many other things. We have a very complex understanding of the nervous system of the body now. And so what we can often do is, depending on where areas of pain are, we can, target nerves that supply feeling to that area, and we can go in and selectively block those areas. So that's a big part of what we do.
So that's specifically related to nerve blocks and ablations. Right. So when you do an ablation, a nerve ablation, is it more permanent, more longer term?
Yeah, that's a good question. That's why we do them. Yes. The answer is yes. It's not permanent, but it is longer term. We like to see at least 6 months of relief from an ablation. Oftentimes we get longer than that, up to a year. When we do ablations, we're targeting sensory nerves that supply or that provide the brain with sensations of feeling. And so when we go ablate those nerves, what we really do is we send a small electrical current down at the tip of a needle, and that disrupts the function of that nerve. Eventually, though, when you mentioned permanent, eventually those nerves will grow back. And when they grow back, the pain will return. But it's usually about a 6-month duration of relief. And for many patients, that's life-changing.
Yeah. So you see, I was just thinking about this, back and neck, nerve pain that we're talking about, sciatica, man. Yeah, you probably see more sciatica than you see anything. But maybe that's not true. But you see a lot, don't you?
I do. I see quite a bit of sciatica. It's a very common condition. It's often caused by a pinched nerve somewhere in the back. It could be centrally pinched, or it could be pinched in one of the neuroforamen. That's getting a little bit of into the weeds there. But regardless, you have a pinched nerve somewhere, and there's a lot of different things that we can do to help with those symptoms.
Well, look, my own personal experience. I'm 67 now. I'm in extremely good shape. I walk and run every week, and have for over 40 years. I work out with weights. I do all the things you need to do to stay healthy. But I have a L5-S1 deformity like a lot of other people have. And so I have to be really careful about how I bend. It's, I'll be honest with you. It's really, when I'm running, I have to make sure that I'm upright. I have to make sure that I'm contracting my abdominal muscles. I'm just trying to stay really nice and sturdy. And if I do that, I have a lot of success. When I'm bending over to pick something up, I have to go straight down. That's I can touch my toes, no problem. But if I lean out any little bit, it can start a chain reaction of nerve issues that it would seem at times completely debilitating. And sometimes, once a couple of years ago, it took me weeks to get over it. But what I have found is if I hang in there with it, it will usually go away and I can find my peace again. That's the kind of thing about sciatica. It can be reoccurring, but it can also be through good physical therapy dealt with in most cases.
Well, you've kind of touched on, without probably unbeknown to you touched on a core tenet to my practice. What I tell my patients, and this is true, is this is pain management. Oftentimes I can't cure pain, and I wish I could, but I'm just being honest with everybody. So what I do with my patients is I talk to them about a strategy of how to manage their pain long term. And you have found in your life that if you keep your core muscles strong and you exercise, that helps keep your symptoms at bay. Well, that's a part of long-term pain management. And that's one of the things I try to instill in my patients. Like, hey, I'm going to give you medications potentially. There's procedures that I can potentially do for you, but there's also components and things that you can do on your end. And when we combine all of those things, that's how we're going to manage your pain. There's no one thing. It's often a culmination of multiple things to help manage that pain long term.
What's interesting is kind of been a bit of a theme on the show to some extent, but living in the South, we like to eat. We don't always eat healthy. People tend to be slightly, if not morbidly overweight. And these
I like to eat myself. I'm guilty too.
Me too, man. Me too. You have to, if you really want long-term relief, you have to be willing to contribute. And you see a lot of people that would be better if they would just tend to a couple of things.
Well, absolutely. And then my role as a physician is to educate patients, right? So I try to give them all the tools that they can do. If they're, many times let me just back up. Any modifiable factors on the patient's end, and I talk to the patients about that. And I stress to them, hey, these are things that you need to do on your end, and here's what I'm going to do on my end. And then hopefully together we can come up with a plan to keep your pain manageable. That's really what it's all about.
What's interesting talking to you is you have a great communication style about you, and I was a paramedic at one time in my life and was in pre-med. And I remember so well the whole notion of TLC, giving people the attention they deserve and showing empathy is a really important quality. And when you're dealing with pain management, there literally has to be a give and take between you and the patient, because there's a psychology to it as much as there's a physiology to it, isn't there?
Absolutely. And that's a big point that you just hit on. Acute pain and chronic pain are two different things. Acute pain is short-term pain, typically defined as less than 6 months of duration, and chronic pain is, long-term pain, typically longer than 6 months in duration. Well, as you just mentioned, when you start crossing over into chronic pain, it's not as simple as just, I'm generalizing here, but it's not as simple as just my toe hurts. If you've been dealing with this for 6 months, there's often a psychological component that is a part of that. And so that's part of what I have to address. I mean, it's just not just as simple as let me inject, for example, your toe. It's you got to look at this holistically.
Yeah. I see that so clearly. So when what I like about it, in fact, the new Pain Management Institute that you're part of, the Intervention Pain Management. Let's see, let me get the exact name. Let me toggle up here just a little bit. Singing River Interventional Pain Management Clinic in Gulfport is centrally located. It's in a good position for people who might be driving from all over. One of the things that I'm curious about is when you sit down with a new patient, what does that look like?
Well, this often is, Frank, this is just a discussion. It often starts with about...
Hey, why don't we do this? I asked that question not realizing we're at the end of that segment. We usually only go 2 segments, but if you're cool, we'll come back and do another segment.
That'd be perfect. Yeah.
I want people to hear the answer to that question. When we come back, we'll continue our conversation with Singing River Health Talk with Dr. Joshua Dibble. We'll see you after this. Welcome back to the Ricky Matthews Show and this week's version of Singing River Health Talk. We're talking with Dr. Joshua Dibble, who is an intervention pain management physician, and he's at the new Singing River Interventional Pain Management Clinic in Gulfport. And when we went to break, we usually do just a couple of segments, but as I mentioned, one of our guests had some technical problems, and since she hasn't joined, and this conversation is going so well, and since pain management, frankly, is something I think everybody's thinking about, everybody's wanting to do something about it. So what we'll do is continue our conversation with Dr. Dibble about pain management and intervention pain management. When we went to break, though, we were talking. I just asked him, what does that first meeting look like with a new patient, and how does he assess it? Because as we discussed, there's a psychology component to it, and there's some real physiological components to it. And he's interested in getting people long-term relief, as he has mentioned. So, what does that look like?
Yeah, thank you. So when you come see me for the first time, it's going to involve a detailed history, and what that essentially amounts to is for the first 5 minutes or so, I'm just going to sit there and let you talk. I'm just going to listen. I want you to tell me about when the pain started and, where the pain is located and all the history that you have done and all the things you've done to treat this pain prior to seeing me. And I will interject a little bit and ask a few questions. Once we get a good history out of the way, I'll do an exam. I actually touch my patients. And so we'll do a physical exam. And then after we do those things, I may briefly review let me back up. I always have reviewed the chart and the imaging before I've actually seen you. But at that point in the encounter, we often will look at that together. So I'll go over your imaging with you. I'll look at maybe some of your pertinent lab values with you. And then I'll tell you what I think. I'll tell you what I think's wrong. And then I'll tell you what options we have to treat it. And so that's what you can expect when you come to see me for the first time. I like to listen to my patients, and it's usually about a 30-minute encounter. Oftentimes us doctors get very busy, but especially on the first visit when we're just meeting each other, I like to give the patients, a full 30 minutes. I give them my time, I give them my attention, and we really try to establish a relationship.
Well, how often, we mentioned opioids a minute ago, but how often do opioids become part of the conversation where they're saying, I got to get off these. I got to find, alternative approaches. Does that come up?
Yeah, it does. It comes up, especially if patients have been on opioids for a long time. We had that discussion at that first encounter. And what I will generally tell patients, and every patient's different, so this is not a one-size-fits-all answer, but my general thought process is opioids are a great medication, and they have a very firm place in the medical community. In my opinion, and not everybody agrees with me, but in my opinion, they are best for short-term use. What is short-term? 3 months or less. So you have an accident, you have a surgery, you break a bone. Yeah, opioids are great for that short-term pain relief. Once the pain persists longer than, let's just say, about 3 months, you start dealing with dependence and tolerance when it comes to opioids. So that's when, in my opinion, you need to start looking for alternative ways to treat the pain. And I emphasize this with patients. It does not mean that your pain stops at 3 months. I know that's absolutely not true for many people. It just means that after about 3 months or so, in my personal opinion, opioids aren't the best option to treat your pain. We have to look at other things.
Yeah, that's good. Listen, we talked about epidurals and nerve blocks and ablations. Spinal cord stimulation for long-term relief is one of the things that you have on the list. Talk to us more about that.
Yeah, that's it's under the category of neurostimulation. So what this is, these are little stimulator leads that we place in that epidural space, that same space that I mentioned earlier, where when women have an epidural for their labor, we put it in that same spot. And this will send a small electrical current to the spinal cord. And what that does is it distracts the pain signals from going to the brain. So this is often used to treat patients with lower extremity symptoms or upper extremity symptoms. So pain that travels down the legs, like that sciatica. Now, going back to sciatica for a minute, now this neurostimulation or this spinal cord stimulation is not the first line treatment, but if patients didn't respond to maybe epidurals or other more basic injections, that's when we start thinking about spinal cord stimulation. It's a two-step process. We let people try it for a week. So meaning we put these leads in place, you go home, you try it out for a week. After a week, you come back, I take them out and we have a discussion. If you really enjoyed the pain relief and you feel like it worked well for you, we schedule you for a permanent implant. And that's a game changer for many people. That is it's more in-destination therapy. That's not something we jump to right off the bat. We kind of, try other things. But for many people who've been dealing with pain for a long period of time, that absolutely changes their life.
So Dr. Dibble, what's the relationship between you and a surgeon, for example? Because I would suspect that there are times when you are dealing with a patient and it becomes clear that this is a structural problem that needs to be corrected. How does that work?
Yeah, that's a great question. I work very closely with spinal surgeons. Patients, pain is one thing, but if we start to see neurological dysfunction, what is that? Weakness, loss of the control of the bowel or bladder, things that are a little bit more alarming, neurological symptoms, we work with surgeons on that. Those are reasons that people may need surgery. So, oftentimes in my clinic, we're trying to kind of help people avoid surgery, but unfortunately for some patients, surgery is the answer. And I don't shy away from telling people that if that's the case.
Yeah. What is dorsal root ganglion stimulation?
Yeah, that's another cool technology that came out in the last 4 or 5 years. And what that is, it's for people who have focal areas of pain, specifically like focal knee pain, focal ankle pain, focal meaning isolated, or maybe they have what's called a complex regional pain syndrome affecting one extremity. So what that is, it's kind of like a variation of spinal cord stimulation, but instead of stimulating in the area where you'll cover both lower extremities, we put that stimulator lead in one of the neuroforamen, and it just targets a focal area. Like I said, for example, maybe just the knee or just the ankle. So these are people with isolated pain, not pain in both lower extremities.
Wow, it's interesting. And then you have another procedure that's related to spinal compression fractures specifically.
Yes, that's right. Now, this is not a new procedure. This has been around for a long time, but many people don't realize that, we treat compression fractures in the spine with kyphoplasty and vertebroplasty. That's something that people may have heard of. It's where we use the little small trocars and we get into the vertebral body. Now, this is done under anesthesia, and it's also done using X-ray guidance. But we put little trocars into the vertebral body. In many cases, we're able to put a small little balloon in there to try to restore some of the height of that vertebral body that was lost in the fracture. And then we inject a specific type of bone cement that really hardens and stabilizes that fracture and prevents progression of the fracture, with the added benefit of it, almost in about 80% of people, causes immediate pain relief. So it helps with pain and it also stabilizes the fracture. And that's something that we do quite a bit of.
So I mentioned, my L5S1, and you smile when I said it because I think a lot of people have that challenge in that area of their spine. But as we get older, do we also incur some degenerative, disc disease that kind of goes along with that? So a condition like that, just anatomically, that's not exactly right, is going to get worse as we get older. And you've got specific approaches to deal with that as well, don't you?
That's exactly right. Degenerative disc disease is very common. Your discs kind of act like shock absorbers for the spine. And as we age, they often dry out. So the disc is composed of two parts. The outer part is the annulus fibrosus. It's just basically like thick cartilage. But the inner part is the nucleus pulposus. But that is like a gel, kind of a liquid material. And that's where the shock absorber happens, where the shock absorbing properties of the disc come from. So what we can do for people with degenerative disc disease, we can go in and we inject nucleus pulposus allograft from a donor, and we inject it right into that center part of that disc, that nucleus pulposus, and that helps restore some of the lost fluid of that disc, and it helps give people some restores a little bit of the function of that disc, and helps with vertebrogenic back pain. And that was not available even 3 or 4 years ago.
Dr. Dibble, is that actually a procedure you're doing?
Yeah, I'm doing it, and it's an outpatient procedure. Takes about 10 minutes to do. It's actually pretty quick. It's done, under X-ray guidance.
You've got minimally invasive lumbar decompression that you can do. Tell me about that. Yeah.
The acronym is MILD, M-I-L-D, minimally invasive lumbar decompression. And so what that is specifically for people with those radicular symptoms that we were mentioning earlier, pain that travels down the leg or the sciatica pain. But these are for people, or this procedure is for people who either don't want open surgery at any cost, or they're too old or too sick to tolerate an open surgery. This is minimally invasive. It's done under light sedation. It's an outpatient procedure. And this is an option for people who thought that surgery wasn't an option for them. So that's who I'm targeting there with that. And again, this is not to steal business from my spine surgeon colleagues. This, again, is for people who either don't want surgery for any reason, or they just can't tolerate general anesthesia.
A lot of people have heard, if you get back surgery, unless it's really necessary, you may have questionable outcomes. And having a doctor that appreciates that and sticks with you and to make sure that you're making the best possible decisions about that. A lot of people, I don't blame them for wanting to ultimately avoid messing with their back if there's other possibilities to solve, their comfort level. I tell you what, stick around. We'll finish up. We got about 6 minutes to go, but I'd love to ask you about a couple more procedures, and we'll kind of wind it all up when we come back with our conversation with Dr. Dibble. We'll see you after this.
All right. Thank you.
Welcome back to the Ricky Matthews Show. We're visiting with Dr. Joshua Dibble, and I had to apologize for destroying his name. I want to pronounce it every way but the way it's supposed to be pronounced. But he's a pain management physician, interventional pain management physician with the new Singing River Interventional Pain Management Clinic in Gulfport. And this is Singing River Health Talk. Today we're having a full show. It just turned out this way. But he and I have really been on a roll trying to understand the various approaches that are available to him in helping people with pain management. And I've been thrilled to be able to dive into this, because I think, a lot of people, you see this a lot. I'm sure your practice is healthy, but people suffer from pain, don't they?
Oh, absolutely. Absolutely. And by the time they get to my clinic, they've been dealing with it for a very long time. And oftentimes it becomes a situation where it dominates all aspects of their life. You'll hear people say they avoid certain activities, or they don't go out of the house, or they don't, attend certain functions because of their pain. And that's where it really tugs on my heartstrings, because, what life is about enjoying yourself and doing the activities that you love. And so that's my goal, is to try to help people get back aspects of their life that they enjoy.
Hey, just a couple other procedures. I'm sorry, go ahead and finish your thought.
No. One, I wanted to make a quick mention. We were talking about the minimally invasive lumbar decompression procedure, that MILD procedure. Last thing I wanted to say about it is, just want your listeners to know, this doesn't stop you from having surgery should you need it. So that's another thing. I don't want people to think that none of the procedures, I'll just go ahead and make a blanket statement. None of the procedures that I do, if for some reason down the road you need another surgery on your back, you're not going to be precluded from having that just because you had a procedure with me. So I just want people to know that.
And I think it's cool that you guys, because of the tight integration, at Singing River Health System, you have the ability to converse with a spinal surgeon at any time on behalf of a patient's interests. And I think that's terrific. Peripheral nerve stimulation is another choice that you have. Tell me more about that.
Yeah, that's kind of taking some of that neurostimulation or neuromodulation technology we talked about with spinal cord stimulators and dorsal root ganglion stimulators. Both of those modalities are specifically around the spinal cord. Well, this is taking that technology out to the periphery. So this would be for people who have isolated shoulder pain or isolated knee pain, or maybe they have this hip pain caused by cluneal nerve entrapment, things like that. What we can do is we typically will treat that with a nerve block, meaning a simple injection of numbing medicine to anesthetize the nerve that supplies feeling to that area. But if people get good relief, we can go in and put a little small stimulator. So it's a little small wire, a little small lead that is placed around that peripheral nerve that sends a small little electrical signal that disrupts the transduction of pain signals to the brain. And this is for people who want to go, they have shoulder pain, but they want to go play golf. So they have this procedure done and now they can play golf. Or maybe they got knee pain and they've either had a knee replacement or they don't want a knee replacement. This is an option for those people.
Well, it goes back to quality of life. Everyone wants hope and happiness, the ability to connect with the people they love. They want to be able to go, if they love golf, they want to be able to go play golf, or if they love to go fishing or walking in the woods for whatever reason, they want to be able to do those things. And, the key to health and happiness is to kind of feel good about yourself and not have to live with pain. And I think that's the overarching message of today's show. Hey, the sacroiliac joint fusion.
Yeah. So
I don't know why I had a hard time saying that, but anyway, the treatment.
Yeah, absolutely. So the sacroiliac joints are, lateral to the sacrum. They're just below the lower part of the back. That's a specific anatomical location. Many people just say, I have back pain, but it's coming from these sacroiliac joints. Typically we will treat that with a combination of physical therapy, medications, and even steroid injections. But for some people, that combination of therapy isn't adequate, or it's or maybe the injections worked at one time, but they don't work anymore. So for those type of people, we can go in and we basically fuse that joint by basically placing a small screw across that joint. Now, what that does for people is that people don't realize that joint actually does move. It doesn't move very much, but it moves, a few degrees of percent during ambulation when we walk. If you put a screw and you fuse that joint, you stop it from moving, and therefore you stop the pain. And man, that has been a life changer for many people. This doesn't stop you from walking around. This doesn't stop you from moving your leg, and it certainly doesn't stop you from going out and doing the activities that you like. This is just a more permanent treatment for that nagging low back pain that has been refractory to some of these other treatments.
Hey, man, listen, I'm curious about this because this is what would motivate me as a doctor wanting to be connected with my patients. When you have a patient and you see so clearly what you're about to do is going to help them, how does that make you feel?
Oh, I get super excited. I actually have to kind of, tamper my excitement a little bit because I don't want to oversell anything. I don't want to, promise patients something and then me underdeliver. But I get excited. I mean, that's why we do it, right? I mean, all of us doctors went into this to help people. And man, when I do a procedure or I initiate a therapy for somebody and they come back and they say, doc, since I've seen you last, I'm able to do X, Y, or Z. Man, that's what I live for. That's why I do this.
So we're out of time. We're out of time for today, but it's been terrific spending some time with you talking about pain management. And I want to remind people there's going to be a ribbon cutting celebration at Singing River Interventional Pain Management Clinic in Gulfport on April the 16th at 11 until noon. The community's invited to tour the clinic.
Yep. And, from 11 to noon, the community's invited. Come meet myself, meet my staff, come tour my clinic. Ask me any questions that you want. I'll be happy to meet everybody. I invite everybody to come out and kind of see where we're at and get to know us.
You bet. This has been Singing River Health Talk. Have a great day, and we'll see you tomorrow.